Welcome to the new world of remote learning. Today we're going to talk about the bony injuries of the face. That includes everything from the forehead down through the lower jaw. First of all, we need to classify these injuries. A simple or closed fracture is one in which the soft tissue is not disrupted over the bone. So the bones themselves are not exposed to the external environment. Contrast this with an open or compound fracture where the bony fragments are exposed to the external environment. They may penetrate skin or mucosa or communicate with sinuses or involve a tooth socket. So any fracture involving a tooth socket is, by its own definition, an open fracture. A green stick or incomplete fracture is one that resembles a young branch on a tree where you try and break it and it doesn't break cleanly. So it's partially broken but not complete. This is fairly common in children whose skeletons have not been fully ossified. Comminuted fractures are those that have multiple fragments of bone. So this is fairly common in the midface where the bones are fully ossified. Comminuted fractures are those that have multiple fragments of bone. So this is fairly common in the midface where the bones are very thin, where you may have a dozen or more bone segments associated with the fracture. Favorable and unfavorable fractures relate to the muscle pull on the fracture itself. If the muscle pull tends to put the bone edges together, as in the pterygomasseteric sling or over the mandibular angle, and it pulls those segments together, that is considered a favorable fracture. If the muscle pull tends to distract the fragments or separate the fragments, that would be considered an unfavorable fracture. All right, so what you see here is pretty much what I've just described. It should be noted that compound fractures may have dirt, glass, any kind of other material embedded in the fracture, and these materials must be removed before the fracture is treated. The reason for that is that they will serve as foreign bodies that will predispose to infection, and the patient will have draining sinus tracts and infection for a persistent period of time until that material is removed. Those patients also should have tetanus prophylaxis, as you would if you stepped on a nail or something like that. And antibiotics are definitely indicated in open fractures. Now, you're going to see favorable and unfavorable described in two different ways. And I even mention this stuff because this is a potential board question. The way I'm going to show you today is what the generally accepted description is. It doesn't really make sense, but this is what's in the literature, and that's why we're talking about it. So you would think this is a horizontally favorable or unfavorable fractures, but it is in fact the opposite. These are vertically favorable and unfavorable. On the left side of the screen, the right mandible, the muscle pull tends to pull the fragments together, and that is favorable. On the opposite side, where the fracture is in a different angulation and tends to be distracted by muscle pull, that is unfavorable. Even though this is, you're looking at a horizontal plane, essentially, in a real person, this is called a vertically favorable or unfavorable fracture. This is horizontally favorable or unfavorable. Same sort of deal. Depending on the way the fracture lines are oriented, the muscles will pull them apart or pull them together. Even though this is vertical in a standing patient, it is called horizontally favorable or unfavorable. Imaging for fractures can include everything from periapical radiographs to computed tomography, and even some additional specialty imaging techniques. Typically, we use conventional radiography or tomography rather than MRI because the visibility of bony structures is better on radiographs rather than MRI. So periapicals, panoramic, plain films, conventional tomography or computed tomography, all can be used to image these fractures. Far and away, a patient who comes into a healthcare facility with a facial fracture these days is going to get CT rather than any of these other things in almost all cases. Because dentists in general have access to panoramic imaging, oftentimes you'll see that as the first image that is taken on these patients. And this image illustrates a right mandibular body angle type fracture distal to a third molar, and a left symphysis, sometimes called parasymphysis fracture. The area anterior to the first bicuspid teeth in the mandible is considered the symphysis, not just the midline. And these are common type fractures that we see with these patients. Here's a regular plain film, a PA mandible film, which again shows two fractures. So you can see these easily on the film, but it is still only a two-dimensional image of the three-dimensional mandible, so you can't see the fracture in all dimensions. CT scans, as I say, are commonly employed to look at these types of fractures. Here you see illustrated a symphysis fracture in the left mandible, the right side of your screen. By convention, when you do a CT scan, it's as if you are looking at the patient from the feet toward the head. So the right side of the screen is the left mandible, the left side of the screen is the right mandible. CT scans also have the advantage of using algorithms so that you can actually see the bony structures in all three dimensions. So you can actually develop a 3D picture. You can rotate these things around the X, Y, and Z axis to get really good images of the fracture segments. This fracture would illustrate a comminuted fracture of the mandibular symphysis on the patient's left side. And that's because that triangular piece of bone at the inferior border of the mandible represents a third segment. So how do we treat these things? Well, most mandible fractures have some degree of exposure to the external environment, either through a tooth socket or the soft tissue has been penetrated intraorally. So we want to treat these things as soon as practicable. They would typically be contaminated by oral bacteria, which is never a good thing. So when we treat these, two things we want to achieve. One is to put the bony segments back in their normal anatomic position, or as close to the normal anatomic position as we can achieve. And the second is to fix the fracture, to create fixation across the fracture line so that the fracture is stabilized in that position so the bones can heal in pretty good symmetry. When we reduce these fractures, there's a number of ways that it can be done. Closed reduction, not to be confused with a closed fracture, is a fracture reduction in which we manipulate the fractured segments back into normal or near normal anatomic position without making an incision to expose the fracture. You can do this with, and we'll go through the different ways to hold it in fixation, but the reduction itself is just you reorient the segments as best you can without seeing the fracture under direct vision. Close with external fixation. We do the same thing in fracture reduction, but we have a device that penetrates through skin to hold the fracture in its reduced position. Semi-open reductions require an incision, but that incision may not be directly over the fracture. It may allow us to insert an instrument into the area of the fracture to move bony segments, but it's not under direct vision. Open reduction with external fixation, we actually make incisions to expose the fracture sites and then put a device called an external pin fixator on. These are metal pins that penetrate through the skin and have a bar outside of the soft tissue structures holding the things in proper position, so the fracture segments are in the proper position. Open with internal fixation is one of the more common ways that we do these fractures, and that means we expose the fracture through incisions, either through the skin or intraorally, and put devices that might include wires or metal plates or screws across the fracture segment to hold them in normal or near normal anatomic position. So for fixation, we can use any of the devices that are illustrated here. So in the olden days, oftentimes we use splints. And if you look in older textbooks and things, you'll see some pretty bizarre gadgets that were used to hold bones in position while they heal. Commonly still, and especially in children, we may fabricate acrylic splints out of orthodontic resin and put holes in those and wire those things to teeth if the patient has teeth, or wire them around the mandible or the maxilla with wire or pins or screws to hold these things in place so that the bone stays stable enough to heal. If there's movement across a fracture line, there's a tendency for the bones to not heal, and you wind up with a just scar across the fracture site, and the bones continue to move, which, as you might imagine, make it difficult for a patient to eat and are often associated with pain. Arch bars, also called intermaxillary or maxillomandibular fixation, are also commonly used to reorient teeth. So the most important thing when you're dealing with fractures that involve the dentition is to reestablish the occlusion. If you get the bones to heal, but the teeth don't come together, your patient is not going to be happy and they're not going to have very good function. We can use wires to hold bone edges together, but wires have a lot of play and they sometimes break, especially if a patient is functioning across a fracture line. Most commonly nowadays, we use screws and or metal plates to hold these things together, but on rare occasions, and depending on the specifics of the situation, we may use a device that we'll illustrate in a little bit that actually allow us to stabilize the fracture outside the body. You see this more commonly in orthopedic fractures, but we still use it in facial fractures on occasion. So where do these fractures occur?